Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Impact of azacytidine prior to allogeneic stem cell transplantation for myelodysplastic syndromes, a study by the Société Française de Greffe de Moelle et de Thérapie Cellulaire and the Groupe Francophone de Myelodysplasie by Gandhi Damai et al. My name is Jürgen Finke and I'm Deputy Head of the Department of Hematology and Oncology at the University Medical Center Freiburg, Germany. My oncologic specialty is hematologic malignancies and stem cell transplantation. The publication is based on data from the French Bone Marrow Transplantation Registry and examines the role of different therapeutic strategies for adult patients with MDS prior to allogeneic stem cell transplantation from matched sibling or unrelated donors. Between 2005 and 2009, from a total of 265 consecutively transplanted MDS patients, 165 having received prior therapy were selected and grouped accordingly. 98 patients had received intensive chemotherapy, 48 5-azacytidine alone, and 17 5-azacytidine followed by chemotherapy. 3-year overall survival was similar in the chemo and azacytidine groups with 48 and 55% respectively. In multivariate analysis, high-risk cytogenetics adversely affected overall survival and event-free survival, and, interestingly, older donor age adversely affected event-free survival. Several lessons can be learned from these data as follows. First, a majority of patients with MDS can be cured by allogeneic transplantation from sibling as well as unrelated donors. Second, less intensive therapy prior transplant is better than standard chemotherapy. Third, azacytidine is able to induce remissions and prolongs life compared to best supportive care. However, it is not curative, as we know from randomized trials. Fourth, azacytidine is able to reduce tumor burden in MDS prior to transplant and, although this is not a randomized trial, appears to further reduce relapse risk after reduced intensity conditioning. And fifth, importantly, a younger unrelated or sibling donor is better than an older donor. And there are new data out from trials confirming this observation. Is it time to change clinical practice? I believe that it is, as it had been done already in several centers. In this regard, it is reasonable to expect that patients with myelodysplastic syndromes should be referred to and evaluated in a specialized center regarding therapeutic approaches, including the option of allogeneic cell transplantation. Since in the era of reduced intensity conditioning, patients older than 75 years have been transplanted successfully, a thorough clinical assessment regarding comorbidities is mandatory and helpful for therapeutic decisions. Restricting allogeneic cell transplantations to patients up to an arbitrarily determined age is clearly not valid anymore. Several other considerations are noteworthy. First, based on known disease-specific risk factors, an early donor search should be initiated. Second, When therapy is indicated, hypomethylating agents like azacytidine or decitabine should be considered and likely be preferred to conventional chemotherapy for bridging therapy prior to transplant, particularly when a complex karyotype is present. And third, enforcement of CR with blast reduction to less 5% prior transplant is not an absolute prerequisite for long-term survival and in fact could be harmful. Although it may be tempting to continue with hypomethylating agent as long as possible, resistance will occur invariably. Late referral for resistant disease for a possible donor search and subsequent allogeneic cell transplantation really confers an incalculable risk for the patient and frequently results in failure of this race against time. In conclusion, as a nucleoside treatment in conjunction with subsequent allogeneic cell transplantation is a very promising treatment with reduced risk and curative potential. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.